good morning. I'm Dr. Steve Stites, Chief Medical Officer here at the University of Kansas Health System and Executive Vice Chancellor at the University of Kansas Medical Center. Welcome back to Open Mics with Dr. Stites and our monthly edition of my favorite show, Show Me the Science. All right. Okay, cool graphic. I got the cool graphico. Diagnosing Alzheimer's might get simpler in the very near future. Currently, an Alzheimer's diagnosis requires memory tests and in-depth conversations with a patient and their loved ones. Brain scans and spinal taps may be ordered. Doctors need to rule out any other conditions that might be causing the memory problems, but a new generation of blood tests is promising to change all that. Joining me today are two memory care experts involved in both patient care and research. Dr. Jeff Burns and Russell Swerdlow are co-directors of the KU Alzheimer's Disease Research Center, one of the few such centers in the country and in the world. We're talking to two of the leading investigators in this field right now. Gentlemen, as always, it's great to have you both. I love to have you here so I can mess with you both simultaneously. What a great day. Before we discuss these new diagnostic blood tests, though, we sent our camera out and about to hear people's thoughts about Alzheimer's disease. Let's take a listen.
One day she called me at 3 in the morning because she's like, I thought it was 3 in the afternoon. I'm like, look, you're right next to a window. Look.
My Aunt Sandy, she had Alzheimer's for about, I want to say, 7 years. It ended very badly.
I never got to know my grandpa due to Alzheimer's.
I have two friends that one just passed away from it and one has her husband in a nursing home. It's very devastating to the family, the deterioration of the body and the mind.
None of my family is really good with preventative maintenance, either with themselves or anything else. So it would take physically dragging somebody to get it done. But yeah, it would be great to see something that could, kind of find it that early.
I feel like it would help people in the long run because either you can help yourself, like take more vitamins, take care of your body a little bit more, do things to stimulate your brain so that your brain doesn't deteriorate as fast.
I think it would have really helped me get to know my grandpa because I was close with the 3 grandparents that didn't have Alzheimer's, and this was my grandpa that was the most crafty. He made all of the grandkids like personal items, like something spelled out with like their name on it, like a toy chest or like a dollhouse, and it was weird because I was the only one that didn't get to get anything.
It would be absolutely fabulous if everybody could have that test and know. It would be nicer if we had a cure for it.
Yeah, I think it would be nice if we had a cure. I know my family's been directly affected by Alzheimer's, and actually I think you're our physician. So, this is a darn big deal. And so, gentlemen, what's the current process for diagnosing Alzheimer's disease? How do we go about it?
Well, yeah, it is a sort of comprehensive evaluation that we have to undertake to make a diagnosis of Alzheimer's. It takes getting a good clinical history, which takes some time, talking to the patient, talking to the family. We usually do a session of memory and thinking tests. We need to get an MRI to rule out things like stroke, tumor, things like that can cause cognitive issues. And then now we're starting to talk about using things that we call biomarkers, which sometimes include expensive tests like amyloid PET and spinal fluid testing, lumbar punctures. But we're hoping soon, as we're talking about here, that we'll have a blood test that'll help support that.
That's a big deal. So, Dr. Swerdlow, could you explain for us the potential benefits of a blood test, especially compared to a lumbar puncture or a PET scan? And both of those, the PET scan not so bad, but that lumbar puncture, that's not so good.
Yeah. Well, the benefits of the blood tests are that they're not a lumbar puncture or a PET scan. But when we're in clinic and we're seeing the patient, getting the history, doing the exam, and we're trying to guess, does this person have plaques and tangles? We're usually right by just making a guess based on the history and the exam, but sometimes we want to confirm or refute our clinical impression, and we've been using lumbar punctures to do that for really over 25 years. And people obviously are often not enthusiastic about lumbar punctures. More recently, we've been able to do PET scans to show that plaques are present or not. But yeah, that's really a more recent thing. Now, blood tests are, easy. I mean, everyone's familiar with blood tests.
It is easy. So, guys, first of all, let's take a step. Remember this. What are amyloid plaques and tau tangles? What are those tau tangles? I like saying that. That makes me feel cool.
Yeah. Well, okay. So I'll take that one. Dr. Alzheimer, when he described the disease, it was.
There really was a Dr. Alzheimer.
There was a Dr. Alzheimer's.
Okay.
Dr. Alzheimer 125 years ago, and he made an association between people who were losing their memory, who were dementing, and these things that he saw in their brains, which he referred to as plaques and tangles, and that's how we ended up with this Alzheimer's disease, a dementia with plaques and tangles. Over a 100-year period, we learned that the plaques consist primarily of a protein called beta amyloid, which clumps together, and we can see that under a microscope. So we call plaques. And the tangles consist of a protein called the tau protein that also begins to clump up, and we can also see that under a microscope. And now we can see these things in people who are living through various technical approaches, including these blood tests.
Yeah. So the KU Alzheimer's Disease Research Center is one of just, and I talked about this earlier, but it's 7 institutions in the world taking part in something called the Accurate Diagnosis Project. Dr. Burns, tell us a little bit about what that is.
Yeah, great. Yeah, this is something we're really excited about. It's sponsored by a group called the Davos Alzheimer's Collaborative, and we were selected in a really competitive application to be part of this group, and the group's really trying to figure out, each one independently but then working together as well, trying to figure out how to develop sort of a blueprint so that health systems can better tackle this problem, right? We take it on basically at a memory clinic level right now, and that's not enough. We don't have enough memory clinic docs. You can't just get in line and wait 6 months to see us if we're really backed up, which every memory clinic in America is. So we got to think differently, and we got to think, how do we do this, sort of at a higher scale so that everybody who needs help can get it. And so what it is we're working, we're coming up with new ways for our specialists, our memory clinic specialists, to work with primary care docs, and we're working on how do we get primary care docs, all of them sort of better at making this diagnosis, and in particular, as we enter this new age of blood measures, how do we get the primary care docs using those blood measures to help increase the confidence of their diagnosis and the accuracy of their diagnosis? So it's a big comprehensive plan that we're working on.
And is it really important from the standpoint of I can get to therapy earlier, or maybe slow how this disease progresses? I mean, what's the point of knowledge? I mean, every now and then you think about, there's some disease like Huntington chorea in which you can find out if you have it, but there's really no way to avoid the fact that it's going to come. So some people just don't want it.
Yeah.
They don't want to know if they're going to have it. Are we going to be able to do anything? Can we activate some science or something around this?
Well, I'll say, we have new drugs. We've talked about that.
Yeah.
We have new drugs that go after amyloid. That's why amyloid measures, like blood measures, are becoming so important. Is we do have new drugs that can pull amyloid out of the brain. They look to be helpful for sort of a segment of the population that we see. Not everybody, but they look to be helpful for a significant group of patients that we see, and they look to be helpful early. So we want to identify those individuals early, and we want to go after it early to slow it down. It's not a cure.
It's not a cure, but we can maybe slow that progression from 10 years to whatever year, and so that can be helpful. So then who should be getting these biomarker blood tests? Do they make sense if someone has no signs of impairment? Do you do it if your mom and dad have some cognitive decline or Alzheimer's?
Well, the field is arguing that point. On one end of the spectrum, maybe you can use this like a colonoscopy, and everyone turns 50 or 55 and they start getting their blood test, or it'll be like prostate screening.
Right.
On the other end of the spectrum, it's, maybe it's best used for people who have the right context, who are having cognitive issues, and the doc is thinking, I think this is Alzheimer's disease. Do I need to confirm or refute this?
So you two are both specialists here, and we want to come back to how this link here is a minute, but what about primary care doctors? If PCP is asked to order one of these tests, should they do it? How do they interpret the test? Can you actually order the test right now? Well,
the guideline is for primary care docs not to do it as a routine screening test. And I think I would agree with that. I've already had a number of patients in my clinic where they said, I told my primary care doc at my last visit that I forgot where my car keys were, or I came out of Costco and couldn't remember where I parked my car. And they said, hey, let's do this blood test.
For me every day. Sorry, yeah. I'm in trouble.
Let's do this blood test. And now they're saying, hey, you need to go to the memory clinic because it looks like you have Alzheimer's. And then there's a lot of, well, in the appropriate setting, walking someone back from the cliff.
Yeah.
So these tests require a lot of context.
So, and that's like the point. So here's an example. Somebody comes in, their mom has Alzheimer's, and now they think, gosh, am I just normal aging? I'm in my 60s or late 50s or whatever, and all of a sudden I can't remember like I used to. How do you distinguish Alzheimer's or not? Is this new test good for that?
Well, I think Russ said it right. It's got to be the right context, and that's where sort of the art comes in. I think you have to try to understand: is this something that someone's always done, or is this a new change for an individual? And the guidelines, and I completely agree with the guidelines that we right now today we want to be using these tests in the context of people who have persistent, real changes in their memory and thinking. So over time, we're seeing changes that are different from how they were, say, 5 years ago, 10 years ago, and ideally we can measure those changes with the little tests we do in the
I think we've done that test on this program before.
Yeah, we've done one of them.
Yeah. I passed, thank God. So, okay, but can I follow up on this point? So if I have it, if the tests are positive, does that mean I'm going to get it, or is it just increase the chance I'm going to have Alzheimer's?
So that's really the million-dollar question. And unfortunately, the answer to that question depends on how we define the disease, and we're still struggling to define the disease. So on one end of the spectrum, if you have plaques, you have the disease. So in that case, yeah, it's a definitive test. If the test is positive, you have the disease. But, maybe we shouldn't be defining the disease that way, and it's not, and we're not currently defining it that way. It's, you need to, well, it really is complicated because there's a research definition and then there's a clinical definition, and one bleeds into the other, and it gets very complex. But, I would I wouldn't be surprised if the presence of these plaques or showing that someone has plaques is, maybe it's fair to just see it as a marker of brain aging.
Yeah. But sometimes it's more than brain aging, and maybe the blood test would help with that too. Is that fair?
Yeah. Well, so blood test alone is not enough.
Yeah.
Because we know a lot of people have elevated amyloid in their brain and no memory problems. So where it becomes really significant and actionable, where we can do something with these new drugs, is when we're seeing memory changes, clear memory changes, and amyloid in the brain. And then
you begin thinking, okay, this is, you're really at high risk. Let's get you started on the early therapy.
Yeah.
So here's a question, and this gets sciencey too. Is the positive predictive value good? I.e., what percentage of the time, if the test is positive, do you actually have the disease?
Well, again,
or do we know?
Well, it depends again on what the definition of the disease is.
That's fair.
So, I think it's very helpful if I think someone has Alzheimer's disease, or if, let's say I'm seeing someone in clinic and I think they have plaques in the setting of a memory problem. I'm kind of 90% right that they're going to have plaques. I can make that prediction. And it's nice to be verified through that test, but I'm not sure that test is better at making that prediction than me spending an hour with the patient.
Right.
But, for those cases where it's tough, maybe the horse is out of the barn and I can't tell, or things aren't far enough along that I can really see signs to go with someone's symptoms. It can maybe tell me how far, if someone is near a cliff or has gone over a cliff, or yeah.
So just add one point here that
To the cliff.
it's
Okay, go ahead.
really important to remember that the test is a test for amyloid.
Okay.
And it's not really a test. It's not specifically a test for Alzheimer's. It's a test for amyloid. Amyloid in the right context usually almost always means Alzheimer's.
Okay.
And
So
so
90%.
90% accuracy for amyloid.
For amyloid, and that indicates that you're at a higher risk of adult.
Yes.
So then we can think about putting you on the therapy earlier
Yes.
and getting started. Okay.
Yeah.
So
Got it.
past the age of 65, there are more cognitively normal people with plaques than there are demented people with plaques.
Oh, that's good to know.
And a lot of
I'm probably
those,
in there
a
someplace.
lot of those cognitively normal people with plaques will never develop dementia. But you know, if you're having memory issues, and I can see them in clinic, and that test is positive, it's, you know, whatever Alzheimer's is, you probably have it.
Yeah. Isn't that funny? We're still thinking, how do we get the right guidelines? How do we get the right ideas out there? So, okay, so I'm driving in this morning. I'm listening to NPR, trying to get a little bite of the news. I was trying to listen to Alicia Keys. Thought, I got to listen to the news today. So I pop on NPR, going there. And the first thing on the headline is, we're going to be talking in the next hour about people using falsifying evidence about Alzheimer's disease, and that's delayed new treatments. Okay, guys, what's going on out there? I trust that neither of you are into that business of maybe faking the evidence or anything.
Well, okay, so I'm the Western blot guy here.
So yeah, tell us what a Western blot is, Russ.
Well, you know, a lot of modern molecular biomedical research is based around being able to look at things that we
There
can't
it
see
is.
with the naked
It's up
eye.
on our screen. Look at that.
Okay.
That's so cool. There we go.
Yeah.
All right, all right.
There you go.
That makes complete sense to me, right?
So
there.
we have these approaches, kind of like the blood test. The blood test is like a Western blot for a patient.
Yeah. Okay.
And but we can look at things that see if they're there or not there. And sometimes scientists really want to see something that they think should be there, and maybe they're not seeing it, or maybe they don't want to see something and it's kind of there. You know, sometimes people will push their
Push the boundary a little bit.
push the boundary a little bit to try
and believe in it.
because they really believe in it.
Yeah.
Sometimes
Probably
they
not
probably
okay, though. Probably not
fraud,
okay.
Sometimes it's outright fraud, but I think that's the minority of the time.
Yeah.
I think most of the time it's just trying a little too hard to put the best face on what you really believe in, and sometimes you cross a line. Now, you know, it's caused a lot of discussion in the field and a lot of angst. I would say that it's caused a bunch of angst within an area of the field, amongst a bunch of investigators who are arguing a particular part of the disease that's important to them.
Okay.
And I'm not sure that it really, that it's really holding us back in a major way.
Yeah, 'cause, we're holding back new therapies, and it doesn't sound like, from your all's perspective, we talked about this before the program started, it's not really holding back therapies, but it's professionally clearly not the right thing to do, and if you're really up to doing this on a consistent basis, it's going to end your career.
Yeah, well, you know, we who are doing research, we live in a world of confusion, and it helps to prolong that confusion. So in that respect, it's...
You're confusing me here.
In that respect, it's not good, and then maybe what I'm saying isn't so good then. But yeah, you know, hey, what can I say? The truth will set you free.
Yeah, that's I think just sticking to the truth is the thing to do that advances the science more than trying to, as we used to say, dry lab or make up some data because you've overinterpreted the test. So, any other thoughts from you, Dr. Burns?
Oh yeah, no, I mean, you know, it's a big topic. I think it's bigger for, you know, science in general.
Yeah, it's not just here.
Yeah,
we got police this constantly
Yes.
in science because, you know, we rely on science to set you free. Like we always said throughout COVID, right? You know, the relationship between science, faith, and hope really can be strong, but it starts, you got to have really good science to do it. So.
Yeah.
All right, we're going to be here to answer your questions. Send them in using the information on your screen. That includes the chat on YouTube or Facebook, or emailing the Medical News Network. First, now we're going to check in with Doc Hawk and the Hawk's Nest. All right, Hawkeye, it's our first day back with open mic since December. First of all, the most important question in Kansas City right now is Chiefs or Eagles, brother?
Yeah, Chiefs will win.
Because you are the Hawks, so Chiefs or Eagles?
Chiefs will win. You know, we have some people in the studio here that are unfortunately Eagles fans.
We do?
Yeah,
Who?
But well, I don't want to say by name.
He's not going to be employed much longer. Just kidding.
But you know,
Rest of
I think the Chiefs. You know, the Eagles have great defensive and offensive lines, but I think the Chiefs can handle them. I think they can contain Saquon Barkley. You know, make them throw. I think it'll be good. I think we'll get some sacks. Hopefully, we'll get some turnovers. But yeah, I think the Chiefs will get a win.
Yeah, I'm with you. Sure, I'm gonna hope so. I'm probably one of the most nervous guys in Kansas City, not on the Chiefs organization, but that's how I've always been since a little kid, even when we were 2-12 or 2-14 in later years. All right, so but I think we're going to win today because I think the Chiefs are awesome, and I love those guys. All right. So, Hawkeye, how has the respiratory viral season been going so far? Because I want to tell you, hospital admissions are up really high. I think we said it right. We're over 900 patients this week with a bunch of patients sitting in the emergency room waiting on beds. It's been crowded.
Oh, for sure. You know, I will say that for our hospital, for KU Hospital here, certainly for respiratory viruses, we know that our admissions remain high from our data from last week. Still double digits with influenza infection admissions as well as COVID infection admissions or SARS-CoV-2. A little bit lower for RSV, however. But still, influenza and COVID-19 is out in the community, and that is judged by, number one, our admissions, but also the number of tests we're doing and the test positivity of the tests we're doing. We know that the CDC, the federal institutions had paused communication. They still are communicating about respiratory viruses as well as H5N1. I just saw that today as well. So this is data from, I think this was posted January 31st. We did see that there was a peak of people that were going to the emergency department for influenza-like illness, and that is what this graph is showing. And then we started to see a decline, which was great, but then now we are back on the incline. Hopefully this is just a second peak and we can decrease. What that means is that respiratory virus will be decreasing in the community, but just as you said, Steve, it is still pretty high out there, high in circulation for these viruses, but also other common cough and cold viruses, and unfortunately GI illness bug viruses as well.
So it's been a tough flu year, and COVID has not been as bad, which I'm happy about. But there are a lot of viruses out there not named RSV, not named COVID, not named influenza, and they're making people sick. So whether you have metapneumovirus or parapneumovirus or one of these others, there are a lot of different choices that can make you sick.
Yeah, for sure. I think that's exactly right. Just to your point, you know, we saw that big spike of COVID earlier in the summer or fall. It did dip, and you just said we haven't seen as much as we typically would. We would expect COVID to continue to cycle maybe 3 or 4 times this year, but I think right now it's more about influenza, especially when we know the amount of people that have been hospitalized, even children's deaths. I think we are up to like almost 50 deaths in children for this influenza season, which is just a tragedy for sure.
That's nationally, not just here at KU.
No, sorry, that is a national statistic, yes.
All right, so now you've been speaking with news outlets regarding the tuberculosis outbreak here in Kansas. Big takeaway regarding TB, and we'll visit about this for just a second, because I was in clinic yesterday with a lot of patients, and I had one question of TB. I had 100 questions about TB.
Yeah, a couple big points to take away. This is not new. We have known about it since January of 2024. We on this show have reported on it. There was a news article published in a newspaper in August. This is more of an update of that. At that time in August, there were like 47 cases. Right now, I think they're counting 67 cases, and plus all of the context for the contact investigations. What I would say is that we have seen some of those patients here at University of Kansas Health System. I've treated a couple. I have a couple partners, however, that have been working intimately and diligently with KDHE to help, number one, treat patients clinically, but also help with the epidemiology and do the management of that. What I would also say is that the public health health services and the public health workers have been working diligently to do the contact investigations, which is so vitally important in these types of situations where you have somebody who is infected and can be spreading it to others. It's identifying who may have been infected or had that bacteria spread to them by an infected person. So that has been good. The public health response, those workers and my partners have been working diligently for that. We have seen a decrease in the active cases the last 2 months. And overall, the risk to the general population, the general public, continues to remain extremely low.
All right, so that's and the same thing I tell my patients is, first of all, this is not a resistant tuberculosis. We can sometimes wrestle with resistance. We can treat it. But secondly, and remembering that the rules of TB are not like COVID. It's not like I'm in front of you for 3 minutes, I'm going to get it. You got a long contact with somebody that actively is coughing to get tuberculosis from them. It's actually a relatively difficult disease to spread. So that's why it's close family contacts. People are working next to each other for hours and on days that really are at risk.
So I think those are great points right there. So, we know about influenza and COVID. If you are around that person, they're coughing and sneezing, maybe you're next to them when that's happening, you can be in that space and infected. It's certainly not as virulent as measles, which somebody could be walking through the store, have active measles, and even 2 hours later you can come by and get infected with that virus. Tuberculosis is not like that. To your point, you need more prolonged contact with that person. So just walking through a store, maybe being around them for 5 or 10 minutes, you are not going to be infected, or that is extremely low likelihood that you will be infected. It is not like those other entities, which are viruses, which you've just talked about. So I think that's a great point as well.
Yeah, checkout line in the supermarket with the cashier, not a risk factor.
No.
Long-term contact for 6 or 8 hours in the same place as somebody coughing, okay, well, that could be it, but that's relatively unusual. So, yeah. All right, Alexis Tell says you are watching for questions from our community.
I sure am.
By the way, Happy New Year. I haven't seen you for a while.
Happy New Year. You're looking good. I love the tie.
You got to rock your Chief stuff. And wait a minute. Wait. Whoa, it's on the vest, too.
I love it. And I hope that tie is around your head and you're dancing come Sunday night.
I hope that's right.
For joy.
For joy.
So we have some really good questions coming in about this topic of the Alzheimer's test. Stu has a question. Stu wants to know, how does the accuracy of this blood test compare to a spinal fluid test?
Good question, Stu. Really, we use the spinal test as our gold standard. So that's what we're trying to replicate. So we see around 90% accuracy in comparing it to a spinal fluid test.
Marie has a question about a high sugar diet. And I've heard this as well. There's some people are referring to Alzheimer's as type 3 diabetes. Is that something that you have views on, if a high sugar diet can increase your risk of Alzheimer's?
Yeah, well, some scientists have referred to Alzheimer's as a type of diabetes, a type 3 diabetes. It's based on the fact that some of these Western blots that show the activity of different pathways in the brain, some of them that are triggered or initiated by insulin, seem to be dampened. And so you get these molecular looking changes that look like maybe insulin, there is resistance to it. Are you going to get that from eating a high sugar diet? The data aren't quite there. Maybe the diet data say that certain kinds of diets, like Mediterranean diets, where you're not eating a lot of processed sugar, may associate with some reduced risk of Alzheimer's, but I don't know that people are going to eat their way into or out of a diagnosis of Alzheimer's.
That actually leads me to a personal question, because as you both know, my dad has Alzheimer's, and he was treated here until we ultimately needed to place him in memory care. So my question is, if we know it runs in my family, my dad's sister, my grandma, we suspect my great-grandfather had it, when should I ask for the test? Should I be asking to get the test?
Well, so
I was going to say, Alexis, first of all, thank you for sharing that. And I bet there are a lot of people out there that have this exact same question. And so thank you. That it takes a lot to do that.
yeah, and a lot of people do have this exact same question. We get it a lot. So yeah, so right now, no, you don't need to get the test. And we kind of hit on this a little bit. It's what are we going to do with that information? And right now we don't have proof that there are drugs we can use to say to reduce risk long term, but we're working on that. We've been working on that for 10 years, 10 plus years. So we hope in the next 5 to 10 years we'll have a way to, if somebody does look to be at high risk because they have amyloid in their brain, you know, we can do something to reduce that and reduce the amyloid and reduce the risk. But we have to prove that first. And so, you know, I would just take it as, all right, you know, you have a family history, you are at higher risk. When you have a family history, you're at higher risk, but it doesn't mean you're destined for it. And, you know, the vast majority of people who have a family history, it doesn't mean they're destined for it, but it means their risk is a little higher. And it's complex. And do what you can to stay healthy and eat right and exercise and take care of your heart. And we think that's taking care of your brain for the long term.
Yeah.
And if there's a moment for me to comment on that, Alexis, we've been dealing with this issue for a couple of decades. So we have a test called an ApoE test, which can tell us, you know, were we born, were we wired from the store with a higher or lower risk of developing Alzheimer's disease during our lifetime. And you know, we've generally decided, the field has decided, we probably shouldn't use that test just to inform people, hey, this is what your lifetime risk is going to be. A lot of us in this field, we have a family history of Alzheimer's. That's maybe why we're in this field. And you know, some of us, you know, might be very curious to know this information, and some of us definitely don't want to know this information. But they certainly don't mean that something is predetermined or is definitely going to happen. So, you know, just keep in mind the best way to not get Alzheimer's disease is to die young.
Which nobody
What a
wants.
bad idea.
And that's generally not a good idea.
Right. Right. That
All
makes
right.
sense.
You know, and the other part is live as healthy as you can. You guys have proven. Be as active as you can. Those two things are really doing all that you can. And until we get more new and preventive therapies.
Yep.
All right, this has been a great discussion, and I want to hear final thoughts from everybody. Dr. Swerdlow, we'll start with you.
Hey, you know, I think I've said it all, and I'm ready for my close-up, Mr. DeMille, wherever you are.
Yeah. Okay, Cecil DeMille, for those of you who are too young to know who that is, I had to help Russ out here. All right, Dr. Burns.
Exciting time. You know, these new diagnostics are here. We have to use them right, and we have to get all the clinicians using them right. It's not as simple as just opening the door and turning on the test. So we're working hard on that, and it's going to help. It's going to change the field in a big way. And then at the same time, we have new drugs, and so it's an exciting time. So I'm hopeful about Alzheimer's.
Yeah, so you triggered my thought, which is that this is amazing now that we have tests like this that can help confirm or refute whether someone does have plaques, and now hopefully the field will increasingly focus on, like what we're doing here at this center. So what causes plaques and tangles?
Yeah.
So that we can really get to the bottom of this.
Well, and you guys have focused a lot on the mitochondria and different things, but that's a different show me the science, and we'll have to come back to Doc Hawk.
Yeah, so I want to wish everybody a fun and safe time in New Orleans if you're going. I do feel the Chiefs are probably going to win. Hopefully we can win some of those line battles and contain Saquon. But I think we'll have a Chiefs victory. So I know that people are probably going to be gathering for these parties and get-togethers. We can keep you safe. You can reduce your risk of infection. Number one, if you are sick, please do not go out. I know it's hard, but try to protect other people from getting ill. If you do go to these gatherings, certainly if you want to wear a mask, that will help reduce the chance of infection. Avoid putting your hands in your eyes, your nose, your mouth, because these viruses, if people are sick, are probably going to be on tabletops, chairs, door handles, etc. We pick those up when we touch those things, and then we touch our face. That is a good way to inoculate those viruses into our body. And most importantly, please practice good, adequate hand hygiene with soap and water or alcohol hand sanitizer. And that'll be the best thing you do to keep yourself safe and decrease your chance of infection, and otherwise be able to celebrate a Chiefs victory.
Man, I'm with you about that Chiefs victory, and I'm excited. It's tough. It's a big, tough game. The Eagles have a pretty big line, so we'll see how it goes. But you know, I'm a believer. Speaking of belief, you know, I do have a firm belief in science, and even though sometimes people do push the edge a little bit, like it was reported today, the reality is that that's less than a 1% problem. Science is generally exactly what we need it to be. It just tells us the truth as best it can, and it describes it to us in ways that help us ask other questions so we can go deeper. I think these blood tests are an amazing development, and I just think about how far y'all have come in the years that I've known you, and I wonder what that future will hold. We'll do it together, and we have to have the faith we're going to get there. We have to have hope that we're going to get better, have hope we're going to win this weekend, and we have to have the science to help get us there. And together, when we do that, we can be pretty darn powerful. So I can't wait for the next program when we come in and we start talking about, hey, new therapies, cool tests, help us know, new therapies, giving us something that we can really use to treat this difficult and terrible disease. So thanks everyone for watching and listening. Faith, Hope, and Science. We'll see you next week.
If you're perimenopause or postmenopause, this one's for you. I'm Alexis Del Cid on the next All Things Heart. Why so many women feel forgotten when it comes to healthcare and research, and what doctors here are doing to change that. Thursday at 8 a.m.
Subscribe to our morning medical update and Open Mics with Dr. Stites podcasts. Now everywhere podcasts are available.